Immaraju, and I'm a nurse trainer working in the Pain Relief and Palliative Care Society since last 13 years. And I also been one of a training partner from the state of Telangana in implementing. Uh, so whoever is getting joined to this program, please try to mute yourself. So that will be little disturbance to the others. So it's just kind of a request to everybody. Okay, so about me, I've been working since last 13 years in the Department of Palliative Care. A lot of experiences. As a nurse, I started my career, and a lot of difficult situations I've undergone in palliative care in view of controlling the patient's symptoms and all. Out of which, this is one of a topic where I'm more interested in. I would like to share some of the information which I got with my experience and some research programs with you. So let us discuss about the subcutaneous infusion in palliative care. Just give me a minute. That's fine. Okay. So I would like to start with a brief case history. So later on, let us have a discussion about what subcutaneous infusion is all about. So meanwhile, I'm going to give a case history based on one of our patient who has undergone uh, the infusion. So there is a patient named X with the diagnosis of a carcinoma of right breast with the infected wound in the right side of the breast with the lung meds, and her performance score is 20%. So which just means that she can't take any oral feedings, and she's completely dependable on others and with extensive disease, and she's not well to say. That's how we score the palliative performance score. And she also experienced a lot of severe pain in the chest region with the minimal to moderate breathlessness and anxious too. So she is from a very poor family background and resides in a remote area. Remote area in the sense, in the state of Telangana, we have a places where there is no approach of even a primary healthcare center even. So people live in that kind of places. So the question is, how can we help this patient and the family in their suffering? So as you all heard about the palliative care is not just dealing only to the patient, but also look into the family members too. So what kind of health education to be provided? So like I more target on the kind of health education given to the family members even is also main important. So how do we provide a good quality care and comfort during our end of life? So these are a few questions which may make us think about why and what are we doing in these situations. So what is the subcutaneous infusion is all about? The subcutaneous infusion, it is an alternative route to the intravenous, intramuscular, or subcutaneous injections. The subcutaneous injection is administered as a bolus into the layers of the skin directly below the dermis and epidermis. It is highly effective, just like a IV and IM route in administering the medications. There is no big comparison between these two. Like what we found was there is only minutes of difference in a rapid response for the patient symptom control. But when compared to the IV or IM, which is more horrible, when compared to that, the subcutaneous infusions are much better than the other two routes. So this is one of a picture where we use this kind of butterfly wing drip set, which can be fixed directly into the site. So generally we have few sites. I'm going to mention it later. And an IV cannula, a 26 gauged IV cannula, a pediatric cannula, which also can be introduced into the subcutaneous tissue, as well as the needle can be removed. Only the plastic tubing can be inserted into that and can remain for a while. So which doesn't have any other symptoms like pain or any other thing. Many of our patients feel more comfortable and better with this 26 gauge needle. So this is one type of procedure what we do using the different types of cannulas what we have, and the drive fixed up to the IV tubing. So we have a green color packing, so which has an infusion pump where the IV set, the placing of the IV set comes up to the other end, and the other end is fixed directly into the IV cannula or else into the scalp directly. So I think many of you have seen this. So this is one of a material where we use for a continuous subcutaneous. It's called as a continuous subcutaneous syringe drive, and you can just have a look at this, like a lot of drugs together. I'm going to talk about that. Just have a look at this first, and then we'll go up to this. So continuous subcutaneous syringe drive. So this is one of our best product, I can say. Like it is portable and movable. All the drugs can be mixed together. You can see we have a morphine, midazolam, haloperidol. All these drugs combined together. All these are the compatible drugs. All these compatible drugs are combined together, and it runs for a given time, maybe for a 24 hours, 12 hours, or starts from 1 hour to 24 hours. It can also be used in that different ways. So why do we give? The question is, why do we give a subcutaneous injections? So it can be used to give many types of medications. The main reason why we are giving the subcutaneous injections or infusion is all the drugs which are compatible can be mixed together and administered for the patient symptoms. The patient who cannot take oral medications and whoever is in a semi-comatose state can undergo the subcutaneous injections or the infusions. It helps to have a continuous flow of medications and avoid delay. So frequent changing of times, and when you talk about the nurses' schedules or the timings, somewhere I felt that many times we skip up our time, maybe some 15 to 20 minutes. You can see the lag or the gap created in between any of your other procedures or any other patients. So when you talk about that, the continuous infusion really helps in blocking that fluctuating symptoms. So the one who cannot take orally, it is more helpful, and there will be a continuous flow of medications, and also avoids a delay in administering the medications. So as I told you earlier, the drugs with the 3 compatibility can be given through this route. Like we have a morphine, midazolam, and haloperidol, which are compatible. So this 3 drug compatibility can be mixed together and administered. And there are few things which has to be looked into. So which conditions do we prefer the subcutaneous infusion? The patient's experiencing intractable vomitings. For example, there is a patient with an uncontrolled vomiting, and there is no way that you can't administer any oral medications. In my experience, I have seen there are some other routes like transdermal patches available to control the vomitings. But India, I feel like most hospitals doesn't have. We are not been exposed to that situations. As how to control the pain, we also have the patches for the vomitings, so which have a very good action on that. But in India, it is not so available. So patients experiencing intractable vomitings, this is the only option. When you compare to the IV route of administering medications, a lot of our palliative patients are fragile, weak. They lose their fat. So once they lose their fat, you can only see the bony prominences all over the body. It is a bit hard for them to administer IV injections. The only thing is you may have to keep changing it more frequently, or it may get infected. And when you talk about the intramuscular, it is more painful even. The patient may experience a lot of pain in the future. So to prevent that, the subcutaneous route is more preferable. And also when I compare to the IV, most of our patients doesn't get an IV access. It is just because of frequent chemotherapy. Patients' veins are getting extravasated, and a lot of punctures happening, a lot of pain, and the patches all over the body. To prevent that, the subcutaneous route is more preferable, and it is more helpful for the patients too. So in the conditions like intractable vomitings, the subcutaneous port is more useful. And number 2, an uncontrolled pain and could not tolerate oral medications. As I given you the history before, there is a patient with a CA breast and a huge infective wound, and she's also breathless and anxious. I don't think in this situation, with her performance less than 20, where she is in a semi-comatose state, she could not even answer to any of my question. But using some tools for the pain and the breathlessness, we have a severity rating scale for the breathlessness and pain. So based on the tools, we assess the symptoms and addressing the symptoms and try to manage that particular symptom, like pain and breathlessness and anxiety. which are more common in palliative care and patients with the end of life. So based on that, I'm going forward with the same drugs what we have, but instead, I'm not going to go through the IV route, but we also have another route which is called as a subcutaneous infusion through the other route. For this uncontrolled pain and patients could not tolerate oral medications, like patients with the head and neck cancers and cases like CA buccal mucosa who develop fistula, and patients with the tracheostomy and feeding jejunostomy tube is also not possible for them, and patients for whom the Ryle's tube insertion is also a bit hard. So we don't prefer going out to those kind of invasive techniques. So to prevent that, we have another option of controlling the pain and other symptoms too. That's how the infusion goes on in the same way. The patients with the semi-comatose state is also one of a problem where patients cannot take orally, and the family will be more panic. Like I told you about the patients from the remote areas before in my case history, where we have to understand the situations of the patient and the family too. So patient doesn't alone is responsible in that condition, but also the family wishes and worries also has to be addressed and identified. Try to talk to them. Meanwhile, the family can come out telling you that he's not responding. He may need a hydration or do some blood transfusion. These are all the ethical principles what we face every time. So when you in the condition like this, in the patient with the semi-comatose state, you need a good understanding about the situations, followed by a good communication, followed by the team together try to prepare a care plan and explain to the family about how the things are going to be. Even in the semi-comatose state, a lot of patients experience a lot of pain, delirium, and sometimes even vomiting, which will be exaggerated even, and decreased food intake is also one of the major problem for many of our family members. So where we have an option of subcutaneous hydration with which we can make the patient comfortable if he is dehydrated as a lifeline. The hydration is only given as a lifeline in the performance less than 20 to 30, and uncontrolled breathlessness. Frankly to say, breathlessness is one of a symptom where the patient undergoes a lot of struggle. Maybe I think this is one of a situation where we may have to take a step in uh, changing the route of administering medications. Maybe we have an option of giving IV route of medications, but somewhere I feel that the just day after the other, you may have to change the site again, go for the other site where it is more horrible and more painful for the patients too. So to prevent that, the route is more preferred. Subcutaneous infusion or subcutaneous route is more preferred. And in few cases like subacute intestinal obstructions, where the patients may experience a lot of bloating, constipated, feces coming out of as a vomiting through the mouth, which is a bit horrible. We know that they are in end of life. But when we talk about the palliative care, how are we going to make the patient comfortable and the family? This is what the question or the challenge in front of us. What are we going to do for them? In this situation, I feel the subcutaneous infusion is more preferred. The benefits associated with the pain management in this, with the continuous infusion. So it can be used in patients with the poor venous access, like I told you before. Intravenous injections, when there is no access of that is more preferred. Number two, provides pain relief for the patients who are unable to tolerate oral pain medications. There are few patients who were on the regular medications, but still somewhere the patient symptoms are not controlled with the oral medications. So I would like to bring up my experience in the recent visit to Canada in the last year, where I have seen a lot of patients in pain, uncontrolled pain. The whole night, if you feel that the patient is really suffering a lot in pain or the breathlessness, by the morning, the nurses make a care plan, they prepare the whole chart based on the whole night situations of the patient. Based on that, they discuss with the doctor and change the whole pattern. There are few patients whose symptoms are not controlled with the oral medications, oral pain medications. So at that time, they directly prefer the infusion pump instead going out to the same route again or any other route. So subcutaneous route is best and well tolerated for many of our patients. So till the time the symptoms are under control, they skip up to the oral medications again. That's how it is very quick and active. So even we practice the same thing here. If the symptoms are not under control with the oral medications due to any other reasons, maybe it would be there is a chances of subacute intestinal obstructions or frequent vomitings. The nurses may just administer the medications in time, but they don't even think about the vomitings or continuous secretions, oral secretions, nor the retching, nor the nausea. When those are the symptoms which is affecting the patient more, I prefer to go up in changing the route of medications. That is nothing but the subcutaneous infusion. The onset of action takes about 20 minutes for your continuous infusions. The cost are almost half of those associated with the IV infusions. There is no big change in administering the medications, but somewhere it is easily available, and it can be like any of our family members can also be taught how to administer the medications even at home. We also have a home care services provided with a good experience in nurses in the vans. They go out to the city of Hyderabad, somewhere around some 50 kilometers radius, where a lot of patients doesn't like to come back to the hospital or the hospice to get admitted here, and they don't want their last minutes of their life to finish up here. If that is how the situation is, they take another step in teaching the family and administering or fixing a port directly into the subcutaneous tissue and explain the family about how to administer the medications. This is the only option um, what can be provided to the family, unless there is no other option. They doesn't like to come back to the hospital. They doesn't want to come to the hospice to get admitted here, and they wish to stay back in the home. Maybe the subcutaneous infusions can be more preferable. Sometimes even hydration can also be given through that. When compared to the IV route, the cost is almost the half of those infusions. So what are the things to be watched for? Using a small gauged wing butterfly needle with a shorter length. Like I explained to you before, we have a winged butterfly needle, which is 26 gauge. We use it for the pediatrics. And the same gauged cannula, nor the butterfly needle, we use it for the subcutaneous infusions. The site selection depends on the patient activity levels and the type of medications delivered. Sites of selection is nothing but the upper chest. We have upper chest is more easily available and easy to administer for the family members even, or just below the deltoid of both shoulder, just below the shoulder, below the deltoid side, nor in the both sides of the lumbar region, just both sides of the umbilicus, and anterior aspect of the thigh followed by the lateral aspect of a thigh. So these are the sites which we can be preferred for patients based on their activity levels and the type of medications to be delivered. If they're able to move around, I feel that both lumbar sites is the most safest place where the pouches or the infusion pump can be kept, and they can just move around to the washroom. If that is the only problem, like the intractable vomitings nor pain, which is not under control, we can just skip up to the other drugs and can be used. So avoid sites where the tube of the pump could be disturbed. There are a lot of chances of the tubing getting disturbed with the pump. So site should be somewhere close to that area, and it should be more flexible for the patient to move around, maybe turning out to the left or right lateral positions too. Site should be free from irritations, away from the bony prominence and the waistline. There are few other patients who are a bit confused and they need some kind of medications. For example, there is a patient with the buccal mucosa and who is able to take little amount of oral feeds with the morphine, with oral medications, and somewhere one day he became more confused and no oral medications are also can be given. So this is how the situation is. So when you change up to the other route, we have another routes like IM, IV and other routes too. But somewhere when you talk about the patient who is a bit delirious, I don't even prefer the IV or the IM route because frequency and beneficiary number 3 is non-maleficence. That's what is I'm more worried about. In that situation, I go for the subcutaneous infusion, where scapula is a better site. Just over this the scapula bone, we are going to insert it in a perpendicular manner, so it will not damage the patient or injury or anything else. So somewhere it is more easier, and the patient cannot hold it or grab it to try to remove as he is delirious. So when compared to all the other routes, another advantage with the subcutaneous route of administering medications. So as I said, site should be free from the irritation and away from the bony prominences and the waistline. So it should be a bit uh, above the waistline. So where to report for the complications like leakage of medications, or if you find any redness in that particular site, maybe on that site, nor even somewhere you see the swelling over the other site. I'm going to show you a small video about that later. Redness and discomfort at the site of the insertion. Some people may also experience a little amount of pain. Sometimes they have pain, which also has to be addressed, and try to change the port frequently. Continued. So on subcutaneous hydration, when you are administering any infusion like lot of IV fluids, the IV fluids like normal saline, ringer lactate, or 5% dextrose, when you administer that, watch for the local swelling and minimize the flow. So how to control or regulate that flow? It is just based on the localized swelling. If you find the swelling is huge, only then you have to minimize the flow of the fluid. Number two, the patient and the family has to be explained about the route of administration. As none of us know about more about this. So we people are getting trained in palliative care. We might talk more about the subcutaneous infusion, but a lot of trainings we give to the people from the different parts of in India, like we get a lot of other nurses and the doctors where they don't practice the subcutaneous infusions too. But somewhere after the training, they feel that this is one of the best route when compared to all the other routes what they have. So that's how. Meanwhile, the patient and the family also has to be explained about the route of administration. How does a drug work, and what kind of swelling will be seen by them. So how to manage that? They may become panic, and they may be worried about why can't we go out through the IV? The flow is not like an IV; it is going very slow, and there will be some other questions related to that. It may get poked in, or some kind of questions. So we should be in a position to answer to them. So check for the patient's response to the medications. As I told you earlier, if the symptoms are not under control in a given time, for example, next 6 hours, I wanted the patient drug to go in through the infusion. In this 6 hours, the nurse or the doctor has to look into the symptom control. If you still feel that the patient is suffering, and there is no point, you have improved the quality care of the patient. So to improve that, this 6 hours gives you a lot of information about the breakthrough medications administered, and the level of suffering the patient has experienced. Based on that, in the next 6 hours, we may have to increase the dose based on the patient's response to the medications. So check for the device and this battery and the power. So many times we may miss these points. So check for the device whether it is working or not, the battery and the power supply. We have a portable syringe drives, are also few infusions work with the electricity power. Power in the sense the patient has to be on the bed all the time during the time of infusion, and the portable syringe drives is more comfortable, with which the patient can move out. If the performance is good, they can just move around, go out to the washroom, stay for a few hours out, and do their own activities if required. Meanwhile, there are things to be checked, that is checking for the precipitations and crystallization in the syringes. Sometimes when there are drugs which are alkaline and acidic, which are few neutral, and which drugs might look like compatible, but somewhere this when it crosses the 3 drug compatibility, there will be some precipitations or crystallizations in the syringes. So keep looking for that. And approximately hydrating like normal saline or 5% dextrose, approximately 1500 1500 ml for 24 hours can be administered. And it is also be a lifeline, not more than that. And they should be given where the performance is above 40 and the patient really is being dehydrated and the performance comes down. I don't think it is a good option. So we may have to do it for a lifetime, where the 500 ml of normal saline or any other fluids can run for 12 to 18 hours. So in the sense, it just be 1 or 2, not more than that. That means 1000 ml per day is preferred. And end of life, as I told you earlier, only the ethical principles is more important instead of hydration. So what is the best thing we can do for the patient, and what are non-beneficiary also has to be seen. So I feel that based on the performance, the subcutaneous infusions has to go up to the level of 1500 ml per 24 hours. So there are a few equipments required to fix the port. It's a subcutaneous port, and where the port is fixed, and you can just go up changing the doses whenever you want. So all you need is a clean gloves, alcohol swab, and an antibacterial skin preparation, and 26 gauge small IV catheter has also been required. So medications in appropriate syringes and container has to be made ready, and the medication administration record. Many times we forget thinking about this. When you have everything ready, the only thing you have to check is the medication administration record. So what does the doctor prefer? How much dose do you think the patient has to undergo in a given time? What is the duration of the infusion, number one, and the drugs added, and for what reasons the drugs are being added? As I told you in my case history, the patient is experiencing a lot of pain. Number two, the patient is also breathless. Number three, a lot of infection. And we are not going to think about that in the infusion. So one is the pain, breathlessness, and anxiety. To control these three different symptoms, and the patient is an end of life, in the medication record, it should be mentioned somewhere that the drugs which are being mixed together, like we are going to mix some morphine and midazolam to control. We know that morphine is a best drug for to control the pain, breathlessness, and also midazolam. We have an anxiolytes like midazolam to control the anxiety, and even the breathlessness is also suppressed with the benzodiazepines. So all these drugs, when you enter in a flip chart, which gives you a lot of information about what drug is to be added with what, and also when you are giving medications through the infusion, you may have to have an idea about the compatibility. When you don't think about that, you're going to waste all the drugs. So to prevent that, only thing you have to do is just think about, just go through the drug compatibility, and what are the medications to be given in time, and the doses and its calculation is also mentioned. So what are the other points to remember? Use infusion pump at either 12 hourly to assess the symptoms and add drugs if required. As I told you earlier, we have this kind of patients with lot of symptoms, uncontrolled, and many family members may feel that subcutaneous infusion or hypodermoclysis, patients may feel that, or the family members may feel that they have fixed some instrument or whatever it is, and just after that, few hours later, my patient passed away. So family may feel that somewhere it is important to explain them. If not, they may have a wrong information about the way you have been infusing it. So keep changing it. So meanwhile, the nurses have also can maintain a chart on the symptoms and the severity and the documentation. So prepare a care plan, and a team discussion can really help in controlling that particular symptoms. So overall idea of this continuous infusion is giving a good quality care and a good symptom control and a good documentation, so that the family will be prepared more about what is happening, and they can just take a decision even about either to go for that step or not. Thank you.
Video.
Can I play the video?
Sure, sir.
Yeah. So this is about one of our new admission to us. So she was from a very remote areas of the state of Telangana, where she's with the cancer of lung, with a lot of pain, delirious, and Nova, the skincare looks completely bad, and she couldn't take any oral medications, and she's not well. So I'm going to mute the audio, but just have a look at how we introduce or insert the subcutaneous port. So the infusion goes out in this way, and the site has been also preferred by the family. So it is all the dry skin where the patient did not take bath and for a long time. So now the sister is trying to administer or fix the subcutaneous port over the right side of the abdomen. Just pull the skin up, introduce the needle in. So the patient herself wanted that the subcutaneous port to be over there. So she doesn't want it to be over the chest region because she feels more heavy, and she also developed breathlessness too. So we also have another like lateral aspect of a thigh and other sides, but she didn't prefer that, but she wanted that to happen up here. So I just wanted to, with the patient's permission itself, I have taken that picture, this video, to demonstrate it to you. And so for next maybe few hours or days, the patient have to undergo, patient will be put on some subcutaneous medications itself, like injection morphine, or even hydration can also go through this route, and which is more bit comfortable. You need not change it again and again. The family also can be taught about that, because we are planning discharge for that patient today or tomorrow. So meanwhile, the family will be taught more about how to administer medications if the patient is unable to take oral medications. So this is one of the best route, I feel like. Okay, I'm up with that. Yeah, please go ahead, Shiva. Anything else to be discussed?
Thank you for the presentation. If you have any doubts, please ask. Either you can chat or you unmute yourself and ask. Anybody? Any questions?
No questions means nothing went to your mind, nor everything in is your mind. So at least try to answer this question then. Everything is good? Shall we go up to the case discussion then, if they don't have any questions? Nor anybody wants to?
For another 5 minutes and then we can move on.
Yeah. Okay.
One chat question, Swarup. If the subcutaneous port frequently take it out, can or not if we do injection like insulin injection?
Yeah, let me just see the question.
Yes.
Okay, if the subcutaneous port frequent take out, can or not? If you don't, if you do injection like insulin injection, yeah, it's possible. I feel like the frequency. What was that? Okay. The frequency you can say that is approximately some 8 days, 8 to 10 days. If you just secure that site, that will be more helpful. So it can be kept for a long time. I feel like more than the other routes. I think this is the safest route. Even the insulin can also be given through that. Am I clear with that question, or you can just chat in the group? Sophia.
Swarup, can I say something?
Yeah, please go ahead.
Usually at the subcutaneous site, we can keep 5 to 7 days. If there is infection like redness or swelling or leakage there, you can change the site. Otherwise, you can keep it for 5 to 7 days.
So do you also practice teaching the family even? Like it would be a direct question to you and me. Like we have an experience there. Okay. So a lot of family members have taught about that. Even the places from the remote areas also, we pick up some of trained or experienced people who have a good education the background, nor the main person who is responsible. We teach them. It takes a long time. A lot of our patients are illiterates and they don't know how to take care of the patient even. A lot of patients are dumped just like that in the home. Like you can see the very poor skincare for that patient. A lot of patients come out with these kind of situations where it is really a challenging role for us, bringing those patients from a very far places, which is around some 8 to 10 hours traveling from one end of the state of Telangana to the other end. So coming back to Hyderabad is a bit hard. So I feel that a lot of education can really help them, the family, to cope up with that situations.
Yes. And even if the not primary caregivers are illiterate, you can train the volunteers. If they have a volunteers in the nearest place, you can train the volunteers also.
Exactly, but when compared to the state of Kerala and Andhra Pradesh or Telangana, it is quite different. We have very less number of volunteers in the place. Even in the city, we have very less number of students coming out and helping us in taking care of the patients. We just wanted the volunteers to come and at least spend some time talking to them. As we don't have that option in our state, we are trying to take help of the local practitioners. Yeah, they just undergo a very brief training in how to administer the medications, and they run the clinics in that villages. So we try to contact them. We tell them that we have a patient and this is how we would request you to administer medications. We do some video calls with them, and we build up some rapport with that. So each village have at least 1 or 2 RMP doctors, like the small clinics they run. So we can take help of them, and all the medicines will be supplied to them to their home. So he can come at any time and help them. So a lot of issues we face here is, once any new doctor or whoever comes in and administer medications and the patient die, they feel that just because of this drug. So to prevent that, the family is being taught more. We are in that situation, getting every number of patients from the remote areas. So a lot of teaching, and also I work in the government cancer hospital, one of the institute of oncology and regional cancer center, where we see in our OP for more than 70 to 80 patients coming, out of which 50 to 60% are illiterate. So it's a big challenge in explaining about the medications, administering morphine in time. Yeah. So the local helpers are more important for us in this state.
Okay. So another chat question, Swarup.
Yeah.
Can you see this?
Yes, I do. So any idea for skinny patients, where to rotate subcutaneous port if tissued? I feel that the upper chest would be the best site for these kind of patients, even though they are fragile. It is not so painful. Many times when we talk about that, many feel that subcutaneous, it may just get inserted inside, or it may just poke into them. So once you are just placing it in an adjacent way over this subcutaneous layer, that will be more helpful. It will not be more painful, and it can be changed more frequently if required. So that the patients also may feel comfortable when there is a change in the sites of subcutaneous port. So where will be the best site that can last longer? See, there is nothing like that. Subcutaneous is everywhere in all over the body. So the site which is more comfortable for them, if the patient is able to walk around, I feel that their abdomen is more comfortable. And the patient is a bit confused, I don't even prefer any upper chest or the lumbar or the lateral aspect of the thigh. I go up back directly to the scalp, so to the scapular region. That's all. So either sides are more safer and last longer. All the sites are the same.
I think before going to the case presentation, I just highlight few points. This is one of the simple, safe and effective method of method. So, so one of the potential advantage of hypodermoclysis or a subcutaneous infusion is we can able to train the caregivers. They can able to disconnect and connect the needle from connect the tubings from the needle and connect and disconnect and connect the tubings and this is we need a good caregiver for that. This is the important, that vital, that this is one of the potential advantage of hypodermoclysis. Even if the patient is in end of life care, the patients wish to express their interest to go home, you can train the caregivers how to give injection through subcutaneous, how to give a fluid through subcutaneous, and we can able to send them back. And you can follow through the phone. That is enough. And one more thing, if there is a that some sort of pain and swelling will be there, you have to give an adequate explanation to the family members. That swelling will be subside within an hours. So that need to be give a good explanation before you start the subcutaneous infusion. Okay, and if there is a inflammation like warmth, redness, leakage there, you have to change the place, change the site. Better you have to avoid the joints that will that limit their movements. Okay, otherwise if there is a subcutaneous vat there, you can able to introduce the needle wherever the patients want. Okay, so we can move on to the patient story. Today, case presentation will be presented by Mr. James Das. Mr. James Das, over to you.
Thank you. Am I audible on the other side?
Yes, yes.
Yes. Good afternoon, everyone. My name is James Das. I'm working as a staff nurse in Boros Memorial Christian Hospital that is in Alipur, Assam, India. So today I'll be presenting a case presentation. My patient is a male patient who is 59 years old, and he was diagnosed with cancer of the parafrontal sinus with lung metastasis. So the presenting complaints on first visit by the team, that is on 2nd of October 2020. He had edema, puffy kind of look present over the orbital ridge and his face. And he had complaint of moderate pain, and according to numerical pain scale, it was 6. He was on pain medication at that time, so the pain in the numerical pain scale was 6. Then he had hoarseness of voice and decreased sensation and mobility of his left arm, and loss of appetite, difficulty in swallowing food, formation of ulcer on the left lateral aspect of neck, and difficulty in performing self-care activities by self. History of illness. The patient had a history of tonsillitis 3 years back, and as a treatment, tonsillectomy was done in the year 2017. And on review after surgery, he complained of persisting pain and change in voice over a period of 1 or 2 months. And further investigation was done, CT scan was done, and it presented, which was suggestive of malignancy in parafrontal sinuses, Then after that, he was referred to CCH, that is Kachar Cancer Hospital, that is in Kachar, Assam, for further evaluation. And he was evaluated there and diagnosed with CA parafrontal sinus with lung metastasis confirmed via CT scan. He was admitted and treated in CCH and undergone chemotherapy and radiation therapy there. The patient had a relapse and palliative chemotherapy was also given earlier this year, that is 2020. And at present, the patient is at home on oral medication. On 29th November 2020, he was brought to BMCH emergency with complaint of unable to swallow and a hard mass present on the throat, which was causing obstruction. So NG tube was passed to support intake and capped methylcobalamin was advised. Next slide, please. On examination, this was the first visit by the team on 2nd October this year. The patient's face was swollen over the nose, orbital ridge, and forehead. Patient was looking weak, and when we took history, he said that he had significant weight loss. And there was mild pain present on the head and left side of the neck and shoulder. Upper arm. In the numerical pain scale came up to 6. Then there was decreased mobility and sensation in left arm. And he had loss of appetite and difficulty in swallowing hard food. So the family used to give soft diet. And he was unable to perform self-care activities by self. His wife or children had to help every time. And general weakness of body and body ache due to long periods of bed rest, and mild breathing difficulty and hoarseness of voice. An ulcer on the left lateral aspect of neck was present, as we can see in the picture. At first, the ulcer was just about the thumbnail size, and then it kept getting bigger, and this was the picture. Next slide. Treatment and significant investigation. The diagnosis was based on CT scan findings, and patient had undergone chemotherapy 6 cycles, which was completed on 12th of February 2018. And patient had undergone radiation therapy after that, 35 fractions, which was completed on 24th February 2018. And therapy 6 cycles was also given this year, which was completed on 6th of 7/20. And he's on level 3 pain management of WHO pain leather. And his medicines are TAP morphine 10 mg every 4 hourly, TAP pentop 40 mg OD, TAP ondansetron 8 mg BD, TAP paracetamol 1 gram TDS, which was discontinued later on, and then TAP gabapentin 300 mg BD. Psychosocial aspects. The patient is a retired military personnel, and he lives in a remote village about 25 kilometers from my hospital, BMCH. He has a wife and 2 sons, one daughter who takes good care of him. Brothers and other relatives live nearby his house who are also supporting his family financially and with other household matters. They all live in the same village, and it's a small colony of brothers and other relatives. And he knows about his illness and that he will not survive long enough. However, he is a strong Christian and says he is ready for whatever the Lord has planned for him. And he reads his Bible whenever he feels comfortable, and at other times he listens to recordings of sermons through phone. He prays regularly with his family and other friends. And he feels better whenever any relatives or friends visit him, along with church elders and other members of his church. Whenever they visit, he feels better. He gets support through that. His medications, home medications, Level 3 pain management of WHO pain leather. Tab morphine 10 mg every 4 hourly, which subsequently got titrated, and at present he was at 25 mg every 4 hourly. Then tab pentop 40 mg OD, tab ondansetron 8 mg BD, which was discontinued. Tab ibuprofen 400 mg TDS, discontinued as well. Tab PCM 1 gram TDS, discontinued at present. Tab gabapentin 300 mg BD, and tab bisacodyl 2 tabs HS. The patient's main concerns. His concern was the financial support for family. He is receiving pension, but still he could not support his family anymore properly. So that was one of his main concern. And children's education. Children are still studying, and so he was worried about the children's further education after his death. And relief from pain to have a painless death. And patient's wife's main concern is that he remains comfortable until his last times. So the summary: a 59-year-old male patient with a history of tonsillitis who had undergone treatment. Tonsillectomy was done. On review, he had continued pain and change in voice. He was evaluated and suspected of malignancy. So he was referred for further evaluation to Kachar Cancer Hospital and diagnosed with cancer of the parafrontal sinus with lung metastasis. He had undergone treatment in Kachar Cancer Hospital. Chemotherapy and radiation therapy was given. He has received palliative chemotherapy as well this year. And at present, he is at home and taken care of by his wife and children. He is a spiritual person and spends most of his time reading Bible and listening to sermons and praying. Family is supported by his brothers and other relatives. Discussion points. How can we support the patient and family in end of life stage? What other symptoms can we anticipate at this stage? And how can we manage the symptoms? And how can we support spiritually? Is pain management adequate? Thank you. That's all for my presentation.
Thank you, James, for the excellent
Thank you.
presentation. If anybody need any more clarification regarding this patient story, please ask. Otherwise, we can move on to the discussion points.
I said earlier, I feel like the patient doesn't have any breathlessness. So he had lung meds too.
Yes, sir.
Yeah. So doesn't he have any breathlessness? Have you identified that? Maybe
Yes, ma'am.
the
Yes,
oxygen
sir.
demand, nor the breathlessness, or nor the anxiety, worry, fear about that. Did you address any kind of because he's having that lung med, any examinations or something?
In examination, in complaints, presenting complaints, he had mild breathing difficulty, and mainly he was worried of his change in his voice.
Yeah. Okay. So these are the multiple factors, like harshness of voice might not be the main cause of the breathlessness somewhere. Okay. So as you said, that patient is had a history of tonsillitis, so which might also leads to the harshness of voice too, and the swelling around the neck would be another aspect. A lot of issues there. So is there any examinations undergone regarding the lung metastasis? Any PET CT nor any CT scan of the chest or revealing that his lungs are clear? Because this is one of an anticipatory plan. So many times when we see such patients with these kind of symptoms, like your question was very relevant regarding the same point, I can say. So about this anticipatory plans, we can even have to talk about the lung metastasis. Patient may develop pleural effusion or breathlessness, vice versa. Again, the anxiety, breathlessness, panic levels, it is a vicious cycle. So I just wanted to mention that.
Yes, sir. He had only mild breathing difficulty on examination.
Okay.
And
Are those lungs clear? Like you You hear any creps or wheezes, ronchi, anything?
We haven't done, we didn't do any this one auscultation at that time, sir.
Okay. So I feel that when you talk about the patient with the lung metastasis, it is more important to think about that. Some kind of anxiety relieving measures also has to be mentioned in our discussion points, right? In our anticipatory plan at that stage. Not just about the pain, but also the breathlessness is more complicated at that time. Meanwhile, with the pain and breathlessness combined together, and the patient may suffer a lot.
Yes.
Yeah, please go ahead, please. Sorry.
I think we can move on to discussion points. Swarup, over to you.
Yeah. Thank you. So, do somebody want to ask any questions in the meanwhile? Or somebody would like to add some points to this? Please go ahead.
I would like to add one point. The case presentation I submitted earlier, and then just on the 3rd of this month, that is December 3rd, the patient passed away at his home.
Okay.
So presently patient is no more, he is expired.
Yeah, maybe that would be a new point which to be added to that. So
yes, I could
it's
not
important,
edit.
when you talk about the discussing points in this. So these are all the things which may change in a day. Just remember that.
Yes.
So did not give a lot of time, lot of break to that, because as I told you earlier, in my presentation, you have seen that patients with the palliative performance score or the scale. Did you see that? I mentioned it as a 20, 30.
Yes.
So was the patient able to, when on your last visit, was the patient able to move around on his own? Nor he needed some help?
In my last visit, he could sit on his bed and try to have his food.
Okay.
That much.
So that is a time where we may have to have an anticipatory plan. So how do you think the death was? Did you ask the family that did he suffer in his last few hours? Was there any question?
After he visited our hospital once for the NG tube insertion,
Okay.
after that, since then he could not. He started getting weaker and weaker since then.
Right.
Just a few days after that, he passed away.
Okay.
So the last part, the family they knew that he would be dying off in few days. They knew, and he was weak, but he didn't complain much. He didn't have any kind of like restlessness during his death.
Okay.
Family and friends were all around praying together, and they kept on staying around him.
Okay, that's good. Mr. James, I have another question for you.
Yes,
so,
sir.
How do you think the patient would have died? Are there any crisis symptoms or the crisis plans which might have made the death happen very soon? I mean, the question is, like, are there any other symptoms like sudden problems which may leads to death? Can you just mention few? Anybody from this? Like all of you have seen this case history right now. So based on that, what are the sudden issues which may leads to death? In particularly in this situation, parafrontal sinus with the lung mets, and patient could not swallow oral feeds properly, and he has come back for the Riles tube incision. What is the most important thing that patient may have a sudden death? What do you think? Exactly. There was an answer from Danita Prakash to everyone. Aspiration. Very good. I really appreciate that. This is one of a point where we have to look into. So patients with some kind of head and neck cancers or the lung mets and breathlessness, this is a point where I felt even sometimes just because of the oral feedings, the family will not be stable, not be comfortable if the patient is not taking oral feeds. Every of our family members may feel that, okay, my patient is not eating well, so I'll stop eating. Somewhere there will be a conflict between them sometimes, and they're more anxious about my family person is not able to eat food in time. So they try to force the patient, and even though the patient is not in a stage to eat, they try to take that, and sometimes it may get aspirated even, isn't it? So this is a sudden, this would be one of a cause of a sudden death of the patients. Maybe what are the signs you see when the patient is aspirated? How do you confirm that a patient has aspirated? Anybody?
Choking, gasping.
Choking, cough, and secretions come out. Maybe the vomiting can also lead to aspiration, isn't it? So these are the few symptoms where you can see, okay, addressing those symptoms and explain to the family. That's what we call it as a serious illness conversation. When you visited the patient last time, when he was all right and not facing any other symptoms, you'd have addressed a few complaints like what are his wishes, how does he want his future to be, and is he worried about his condition. A lot of communication gaps would also be filled at that time. That is a time. So many of our patients who ever come to us, we start talking about the serious illness conversation. We just talk about the conversation, that's it, about the serious illness. So patients and families may come out with a lot of issues, that his wish is this, his worry is this, and he wants to be like this in his last few days. He doesn't like to depend on somebody. He wishes to see his daughter's marriage. These kind of issues will come out, and meanwhile that is a good plan of action to explain to the family about this. And also, I wish the patient to be comfortable, but somewhere I'm worried about these anticipatory symptoms. That's how it has to go, I feel like. So every time we practice the same, so you can also add that, so the family will be more prepared. Talking about the end of life, every family will be more panic, and they don't like it because it is just bad news. So breaking this bad news really is more complicated, and it's a bit challenging. You have to be more prepared about that. So the way we can support the patient and the family in the end of life is, you have done a good job in controlling his symptoms, the physical symptoms, nor you've addressed a lot of spirituality, psychosocial issues, and his wishes, like he's more comfortable listening to some music, a Christian devotional music, and also he loves to read the Bible. That was very good in supporting the patient in the spirituality. So somewhere supporting the patient and family in the end of life, the situations may change. It might not be like what you have seen during that conversation. When the days pass away, the patient's performance may become more worst, where all those relevant issues might not be the same again. Maybe at that particular point of time, the family should be prepared. I feel like the family should have information about how his last few days are going to be. What are those aggravating factors which may leads to the patient, which may leads to the suffering. Yeah. So that kind of information can help them. Not even I feel that, was he able to take the oral feeds till the last day of his death, is what my question is. I don't know what really happened there, but somewhere you got the information that patient passed away. So might not be the rice tube. Maybe the subcutaneous infusion would have helped them. Maybe in a frequent visit, I think so. Yeah. Do you agree with that, Mr. James?
Yes, sir.
Yeah. So how frequently do you call this patient in general when you visited him for the last time? Later on,
Yes.
how frequently did you call that patient to find out his symptoms?
Sir, basically the patient was under treatment of Kachar Cancer Hospital, which is, we are not having any networking with them.
Okay.
So they just come here. Only time they came here was once last year, 2019. And then the next time was for the Riles tube insertion, because the Kachar Cancer Hospital is further away from us.
Okay, that's fine.
So we are nearer, so they came to us. So generally, we don't call them for review here, sir.
Fine. See, one thing I could add, you have done a great job. Like whatever the resources is available for you, you have reached to the mark. But somewhere I feel that at least a telephone consultancy, a video call, and also talking to that main curative treatment doctors or whoever it is in controlling the symptoms, or that's what we do here. We don't have a good rapport with all the hospitals in the city of Hyderabad, but somewhere when they go back, we collect the information or the phone numbers of the doctors, and we talk to them, tell them that we are also supporting that patient. Please let us know what is happening, so that we also have our own plans. If something goes wrong, anyway, the palliative care is responsible. Yeah, at that time we can take a complete role of the patient, or we can just have a conversation with them in helping. I also work with neonatal palliative care in one of our different hospital. It's not a cancer hospital, neonates, all the preterm babies of palliative care, which is all new for us to say. So it took a lot of time for me to communicate with those doctors. Different doctors from the different hospitals come up to work there in that one of a government other hospital, a pediatric hospital. So a lot of communication happens with them. So when you have a good rapport, try to build up that rapport, and that will be more helpful for you. See, they even call me once in a while regarding such patients, and this is what we have planned. So do you have an idea, or do you want to support in a different way? So we tell them that we appreciate that. A lot of communication can really break those issues, I feel. Yeah.
Yes.
Yeah, you've done a good job. That's great. Keep it up.
Thank you, sir.
So what other symptoms? Yeah, please.
Sorry, this one regarding that networking window. I have got contact from the patient itself about their the doctor whom they consult, and I've tried to communicate with them, called them up a few times, but because it was this COVID times and their hospital was a bit busy, so they could not give me proper feedback at the time, so I couldn't communicate properly.
That's fine. At least you reach to that level. I appreciate that. But some way we also face the same problems every time in our state. We have different palliative care units. Nearly 8 to 9 units have been started in the state of Telangana, in all the government hospitals of different districts all over the state. So we don't have a good rapport. Like new hospital, new district government hospital doesn't mean that we are so comfortable with them. So nobody cares us, and they don't give an information to us. But some way it takes time for you to go and talk to them. There you have to just build up and provide some information, share some information with them regarding the care to be provided with the of the patient. That's how we even do it. You've done a good thing. And let's go to the next question. What other symptoms can we anticipate at this stage? Probably, like you said, it would be a crisis plan. It would be aspiration, number one. And patient also may develop vomitings, and maybe the bleeding tendency would not be so severe in this stage. When I saw that picture, there is no much bleeding tendency, but somewhere I feel that in your anticipatory plan there should be we call it as an emergency bleeding kit, a small bleeding kit which has sucralfate and dark cotton cloths and no medical equipments at all. The sucralfate syrup, which controls the minor bleeds. Number two, the dark cloths, which controls the bleeding, and it is not visible to everyone. So we don't use a white cloths or white we have dressing pads. We don't use it. So on white, the red is more visible. So to prevent that, we use a dark cloths, a little amount of bleaching powder placed in a separate packet and given it to them. So sometimes, an unwelcomed situation may be faced at that time. Suddenly the patient may have bleeding, and it might spread all over, and it be more contaminated to the family members even. They may become panicked by seeing the blood all the time, no? So to relieve that symptoms, we may have to have some lorazepam placed in an emergency. So only thing is, when there is a bleeding, you may just have to open it and administer the medicine so that the patient's anxiety level come down, and try to do all the basic things. That's how we teach the family out here. So this is a brief about the bleeding management. And a good oral care. I think oral care also plays a major role in that. When the patient have developed the hoarseness of voice, it itself means that maybe the oral cavity might not be good, because the patient has undergone 6 chemotherapy and 6 palliative chemotherapies too, and a lot of radiations too. So have you ever identified for mucositis? I am more worried about that.
His oral, they were maintaining proper oral hygiene.
Okay,
Proper
it is
hygiene
clear.
was maintained.
There were
Yes,
no
sir.
mouth sores or ulcers developed in.
No, sir.
Okay, that's fine. Okay, maybe I may look for that, and also the breathlessness.
Yes.
So
Yes.
probably there is an option where the situation may become worst. So how do you want your patient to be at that time? I may ask the direct question to the family. If he is in end of life, how do you
Yes.
want him to be? Where do you want him to be? This is where the family, whoever the decision makers are in the family, can think about it and get back to you. So tell them that, okay, this is what we want. I wanted my father to be comfortable without any
Yes.
suffering. Okay, if that is how the situation, we have a plan of the infusion,
Yes.
changing the route from oral to the subcutaneous.
Yes.
Yeah. So these
Yes.
plans has to be explained to them and documented well. So even you are not there on the work today, and whoever the nurse is working on the other day or any other times, so they
Yes.
can go through the same information and share it and start doing the work. I feel
Yes.
that should be done. That's it. Nothing more in that.
Yes, sir.
How can we manage the symptoms? It's all like I said, changing the route of administering the medications. And if it's a big thing to say, like managing the symptoms in the end of life. It's a bit
Yes.
different. The patient may become bedbound. So bedbound may develop bed sores, and they may develop also feeding issues and a lot of worries, a lot of issues on hydration. Family may ask you for the blood transfusion, hydration, do something. He's not eating. Insert the rice
Yes.
tube. You have done it even. Yeah. So these are all the queries or the questions the family may experience. So this is the time where you may have to think more about it. Supporting about the any question, Shiva, anything else you want to add to that?
Yeah, one more thing, death rattle. So during the end of life stage, so death rattle one of the most important symptoms. So we have to explain the caregivers about how to manage death rattle because of the pulling of secretion into the esophagus, the throat. So during the breath, that will cause huge sounds, snoring sounds like that. So you have to educate them how to manage it. You can keep the patient in a sideline position and give proper mouth care, and reassurance is also very very important. And if the secretion is not controlled, you can move on to the pharmacological management like subcutaneous glycopyrrolate or buscopan, like
Yes.
that.
Thank you, Shiva. Thank
Okay.
you. So, and again, talking about the support on spirituality, this is what the patient is needed really. Like his wishes and wishes were been addressed very well. So he is happy and comfortable reading the Bible. He's
Yes.
happy and comfortable uh, listening to the music or the ceremonies there.
Yes.
So maybe I can't say that it is not a part of his life, but it is also a part of his life. He's more comfortable and happy with that. So then it is important to address and tell the family that please try to provide this even in his last days of your life. The communication plays a major role in that. When the condition is good, the family members may listen to that and leave it just like that. When the situation comes, it is completely different. They are not undergoing any training like we do, right? So they may forget about that. So meanwhile, it is our responsibility to remind them that, okay, these are the wishes of the patient I have addressed. Try to fulfill those wishes in time. You may have to remind the family all the time. And also, maybe in end of life, maybe we may think more about the physical and other issues, but somewhere I feel that the memories are also plays a major role in that. Did anybody expect, what was your surprise question of this patient in your last visit? Might be the home visit. What would be your surprise question? How long do you think the patient will live? A question to James.
Sir, pardon, sir.
So how long do you think the patient will live it's just a personal information. I'm not discussing with everyone. So
Yes.
how do you think the patient condition is in your last visit?
Mm,
And how long do you think he'll survive?
okay. My last visit was on the 1st of December at his
Okay.
house, and at that time he was already bedridden, and he couldn't talk anymore. That time he could just give hand gestures with his hands. Then that was the condition at the time, and I had no idea how many days he might survive after that. The
No,
family
what do you
were
think? I'm asking about your internal question.
okay.
So inner thought. So what do you think? Like, how long do you think he may live?
I felt like he might not survive that week.
Yeah, that's a good thing. That is a
Yes.
good sign for you. Like you have very short time. You felt that the patient may die in a week or 10
Yes.
days. So if that is how the situation is, you would have gone to the next level of talking more about the bad news and his end of life to the family. Maybe it would be a challenging time for you, and it is a learning point to everybody that in your surprise question, I feel that the patient is not doing well. So this
Yes.
is the time for you to think more about that. And also maybe at this time, the memory making is also important. The family is
Yes.
not prepared. Family is not prepared about his death and dying. Like he's going to die in that particular day.
Yes.
So try to create an environment where all his wishes and the family members are close to him, comfortable. Lot of pictures are taken, and
Yes.
his likes and dislikes would be
Yes.
done in an appropriate way. Yeah. So these are all the memory makings. So even the patient passes away, those memories may remain back with the patient. So I feel that that's also an important thing which can be added at this moment.
Yes, sir.
Because it is a short time. Maybe that would be an experience for every one of us. Next time when you have such patients, we would have this kind of anticipatory plan before and try to manage
Yes.
the symptoms soon. Yeah.
Yes.
Yeah. And so is pain management adequate? So I have another question. Like the patient is unable to respond to your commands. So how do you address the pain then? The patient
Uh,
is not able to answer to any of your question. Like you said, you use the numerical rating scale. So
yes,
how
sir.
did he answer to your question?
Uh, that scale rating was done when he was able to talk. He was stable at that
Okay.
moment.
So
That
what
was
about
the
the
first
last visit
visit.
on the
The last
December?
visit, the last visit he indicated with his hand. I did not take a scale at that time, sir. I did
Okay,
not rate pain at
that's
that
it.
time.
That's okay. Shiva, do you want to add something to this? So how to address the symptoms in the end of life, like the pain?
Yeah, we can, while we change the position, the facial expression, we can watch the facial expression. That time we understand that whether the patient is having pain or not. That is the only way. I think during the position changing, like pressures or prevention, we need to change the position. No, so instead of
Yes.
2 to 3 hourly, we have to change after 4 hours. So while we change the position, you have to check their face. Is there any change or not? So
Yes.
if it is happen, you can give some analgesics before that.
Yes, sir. Yes, ma'am.
So I have another question. Sorry, Shiva, if I'm interrupting
Yes,
you. Just finish
yes,
with this. Are you up with that?
yes,
Are
yes,
you? Do you
yes,
want to
yes, yes.
continue? Okay,
No,
fine.
you can.
Okay, sorry. Okay. So I have another question. I have mentioned about the bowels and bladder. Can you just brief about that bowels and bladder as he's bedbound? Mr. James, am I audible?
Yes, yes, sir.
Yeah.
Can
How
I
about
can
his?
you repeat, sir?
How about his bowels and bladder?
Bowel and bladder, they were normal, sir. It was decreased bowel movement and all. Motions were a bit reduced in the last part of his life.
Did he experience pain over the abdomen? Did you address?
No, no pain
No.
over the abdomen, only around the neck.
So maybe it's a time for every one of us to think about the care of the bedridden. as he is bedridden. When you talk about that, there are a lot of issues like Shiva Madam has told you about the death rattle, so which has to be addressed and managed. Number 2 is about the bowels and bladder, which may leads to a lot of abdomen pain. Number 3, is he able to move out to the washroom? Is the patient doing everything on the bed, like using the dappers or the bedside commode, not the bedpan?
Yes, bedside. They were using bedpan. In the last part,
Okay.
before that, they would just hold him and take him to the toilet.
Okay.
But later,
So which is
he
a bit
started
hard,
doing
you know. So there, the education has to be added up to the family. Like they live in the remote areas, very far away from your hospital. I'm sure that it's a bit hard for them. So somewhere, this kind of education has to be given. Just look into his age. Somewhere it is around 59 to 60 years of age, right? So at this age and the extensive disease and his performance would be very poor. So taking out to the washroom is a bit hard for the family members even. We also take care of the patient nor the family even too, right? So teaching them, and their safety is also important, I feel like. Not just the patient, as well as the family care is also more important. They will be stressed out with that work frequently, you know, round the clock they'll be taking care of the patient. We might take care of this patients maybe for 6 to 8 hours a day. All the other time we just relax, you know. So but the family members, their role is continued for 24 hours. So their stress also has to be relieved sometime. So we may have to look into the bowels and bladder too at this situation. You know, if you talk to the patient just few weeks before or months before, he would have told you the same thing. I feel like when I'm all right, if somebody asks me about how do you want your life ending days to be, I may say that I don't want to depend on my kids. I don't want to depend on anybody. I want to have a comfortable death, which might never happen to anyone. In the fact to say, none of us have a comfortable death, just like an accident and die having a heart attack like that. Many of us will suffer and die, but we wish or aim to have a comfortable death, which doesn't happen, right? At the same, the patient might also have information, or he wanted to share some information to you. It would be, I don't really like my wife to suffer a lot. If that is how the situation, some changes has to happen, right? So it's important, even though you discuss with somebody, try to minimize that symptoms or control that, and whatever it is, but at least addressing those symptoms makes the patient more comfortable. Followed by patient who is unable to respond to your numerical rating scale or the severity assessment scale. The patients who are in the semi-comatose state, if even though the patient is unable to respond, there are few signs where you may have to look into. Yeah. Yes, please. There are few signs for you to look into. Number 1, the patients who are in the semi-comatose state and not responding to your commands for your pain assessment. You may have to change the strategy or change the techniques of assessment. Out of which you have, it is just an observational tool. Number 1, look for the tears. Patients may have lot of tears. Tears generally come in two different situations, where when they feel more happy, you have a lot of tears. When they face a lot of pain, they can't express that, they experience it with the tears. Number 2, scratching all over the body. It was an experience a long time ago when I heard about, is it true that the patients who are in unconscious state also have pain? It is true. They might have pain. When I heard about that word, I just went out to a lot of patients who are in the semi-conscious state and assessed in the same way. A lot of patients scratched their body, and a lot of scratches are found on the body, which itself means that their pain could not be expressed to the others, but some way they are injuring themselves.
Yes.
Exactly. Yeah. Or he may injure the others who is close to them. Sometimes when there's a nurse who's coming closer and trying to address his problem and trying to give some injection, as he's having a lot of pain, he grabbed her and holded her for a while. Or holding his bed sheet, holding the equipments or whatever it is close to him. Very hard. On your physical examination, number 3, when you do some abdominal palpations, examination, the patient might experience that facial expressions would be changed. Look
Yes.
for morning. The patient might scream all the day, the whole night. When in the mornings, when I come back to our hospital, when I address those symptoms, who are in the semi-conscious state, the family says that whole night he didn't sleep. What did he do? He had that low pitched of voice all the night. It itself means that patient is in pain.
Yes, sir.
This is a, like pediatric patients, we have a different kind of strategy, tools to be used, and neonates we have a different kind of strategy in addressing facial burrow and the screaming. It also have a vital role in that age groups too. So it's a bit different. Like pediatrics,
Yes.
we have a different plan. Adults, we have a different plan of using charting, and facial expressions chart. We have a flag scale, and geriatrics we have a different plans, and also semi-conscious, semi-comatose patients also we have the tears, physical examination, facial expressions like Shiva said, and also scratching all over the body, screaming in pain. It all just means that okay, the patient is suffering a lot, so which has to be addressed. I feel that the pain management is adequate. It would be adequate, I'm not sure, but somewhere it would be a learning point for everyone that patient who is bedbound might develop more symptoms when compared to all the other patients due to the immobility, stiffness of the muscles, contractures. They may develop contractures where NSAIDs might be the best role in that. With the change in the positions, like said before, when you change the positions, the patient may have a lot of pain. Facial expressions might be changed.
Yes.
Look into that issues, and maybe that gives you a good pain management. Maybe that regular dose would not be helpful. You may have to go up to the other level. Most of the bedridden patients die just not because of the cancer, may die due to other symptoms like a lot of hallucinations, confused, worried. They lose their hope on their life. Their wishes and everything has been um, dropped out away from them. So they feel that there is nothing to do. I may have to be on the bed all the time. They suffer a lot at that time. So you have to be cautious and look into that issues. Yeah.
Yes, sir.
Go ahead, Shiva. Anything?
Okay. Any more questions? Otherwise, we can wind up. So we had a good session today. Thank you, Swarup, for the excellent presentation and interactions. Thank you, Mr. James, for the presentation and interactions.